Hi, my name's Stephen Bird and welcome to Bird Ultrasound. This is an excerpt from the Fundamentals of Ankle Ultrasound. If you like this material, please subscribe to birdultrasound.com.au to view a large selection of freshly recorded ultrasound education on a wide variety of topics. Happy scanning.
The next thing we'll have a look at is a very common pattern of pathology that results from ankle inversion injuries. So it's very easy to roll your ankle or to have an inversion stress injury of the ankle ligament complexes. And there's many structures we need to look at when we're assessing someone that has had such an injury. So typically it requires some sort of footwear that is prone to causing ankle inversion. So high heels are a great example. And then maybe some celebration on the weekend may lead to some dancing in the high heels. Maybe some foolish event like trying to run in high heels. And then we have the accident with the inversion injury, which looks oh so less than elegant. And then of course the patient will present to our department looking sheepish and a little embarrassed as to what's happened with the moon boot and the crutches and maybe even in the wheelchair, and require us to assess the ankle to see what damage has been done. The first thing is to get a plain set of x-rays to exclude a very common distal fibula or even trimalleolar fracture. Once we don't have a fracture seen, then we can get on and do the ultrasound to have a look for what soft tissue damage has been done. Now typically the patient will present like this with the lateral ankle appearing somewhat swollen and puffy and some bruising starting to come out underneath the lateral malleolus. Interestingly though, when we look at the medial side of the ankle, there often is some bruising just underneath the medial malleolus as well. So the reason for these two lots of bruising is that when we invert the ankle, this anterior talofibular ligament is torn very easily, and then the calcaneal fibular ligament is also commonly torn. So when these tear, then the inversion stress allows the medial malleolus to collide with the tibia, causing this collision and causing the bruising to come out on the medial side as well. Remember that unlike this diagram, these ligaments are actually capsular ligaments, so they actually envelop all of the ankle joint and hold the synovial fluid in place. So when we tear the anterior talofibular ligament, we release fluid from the ankle joint into the subcutaneous tissues, and that is in part what leads to this swelling and edema that we see on the lateral side of the ankle. Now this looks like a long list, but these are the things you need to look at when you're looking at an inversion injury patient. I don't think you can really skip any of these points. We need to look at the ankle joint itself, and then have a look at the anterior talofibular ligament, the calcaneal fibular ligament, then the syndesmosis between the tibia and fibula, so the anterior inferior tibiofibular syndesmosis, the superior peroneal retinaculum that helps to maintain the position of the peroneal tendons. I like to follow peroneus brevis down to the base of the fifth metatarsal, not because I'm worried about peroneus brevis, but because I'm worried about a fracture at the base of the fifth metatarsal. So I'll follow that down and I check for a Jones fracture. Then of course we have the other joint, the subtalar joint. Then the bifurcate ligament, the calcaneal cuboid component of the bifurcate ligament, because it's very common to get an anterior process of calcaneal fracture with, if you've got hindfoot stabilisation and midfoot inversion, this is a very, very common fracture to get. Just adjacent to that, we can look at the extensor digitorum brevis origin, because this can be pulled apart. Then we have the dorsal talar navicular ligament that's injured during plantar flexion. And then on the medial side, you've got the deltoid ligament, in particular the tibiotalar component that gets a compression injury called a POMI lesion. And then the deltoid flexor retinaculum. So the deltoid ligaments and the flexor retinaculum make a conjoint type origin from the medial malleolus, and this can be stripped off the bone there in a degloving type injury. And then finally, I like to look at the bony architecture of all the bones around the ankle and foot, wherever the patient has point tenderness, to see if there's any evidence of a fracture that might be occult on the x-ray, but seen really nicely with the ultrasound. So this is your classic anterior talofibular rupture. So you've got the fibula and the talus there, and you can see there's a bridge of collagen that used to be between them, and now it's got like a cleft running through it, somewhat like a Suez Canal. And that's synovial fluid and blood that's coming out of that ankle joint, and this is a complete rupture through the mid portion of the anterior talofibular ligament. Very, very common injury. Sometimes we will see an avulsion fracture, so you can see the distal end of this ATFL has been tugged off of the talus here. You can see that elevation of the little avulsion fracture, and then deep to the ATFL there, you can see an associated hemarthrosis where that little avulsion fracture has bled into the joint, and you can see the red blood cells sitting swirling and being compressible underneath the ATFL in a hemarthrosis pattern. It's very nice in the paediatric patient. This is a nice split screen comparison between the normal ATFL on the left and the abnormal one on the right, where you can see that there's been a little bony elevation and avulsion here in a paediatric patient. I think the use of ultrasound for looking for small fractures in paediatrics is really, really valuable. Now, Quanson Serlin, a wonderful sonographer from Melbourne and great friend and colleague of mine, has described this anterior modified draw test. So the Quanson modified draw test, where you place the patient prone on the bed, and like the old-fashioned anterior draw test, you're holding the tibia and fibula stationary while you're pulling the talus anteriorly. So to do this, we lay the patient prone, we put the transducer up on the lateral malleolus parallel to the sole of the foot, and this will give the exact perfect location for the anterior talofibular ligament. In fact, if you get your thumb and you slide your thumb here underneath the lateral malleolus of the ankle, and then you put the transducer just on top of your thumb there, up on top of the lateral malleolus, parallel to the sole of the foot, you're looking at the anterior talofibular ligament perfectly. Then if you put downward pressure, so anterior pressure on the heel here, that's pushing the talus forward, and that will create this modified, Quanson modified anterior draw test. So this is an example of us performing the test, and you can see the way that there is a partial tear here in the undersurface of the anterior talofibular ligament here, but not a complete disruption. There's still just a few fibers holding this in place. You can see the way that the talus moves anteriorly relative to the fibula. In this case, you can see that there is, in fact, a complete disruption. You can see the large gap open through the middle of the ATFL. You would expect this would be quite painful for the patient, but my experience is that if you are gentle with your pressure, the patient can tolerate this quite well. And I think it allows us to grade the ATFL injuries far more accurately than just using simple inversion stress. The next ligament to look at is the calcaneal fibular ligament, and that's in this location here, and it sits deep to the peroneal tendons. You can see the peroneus longus and brevis sitting superficial to it here, and it's a long rope-like structure between the fibula and the calcaneum, and when it fails from this fibular end, very rarely from the calcaneal end. It fails from the fibula end, and often degloves. You can see the way that the anterior talofibular ligament and the calcaneal fibular ligament really are quite close to each other here. There is a sharing of collagen across this area, and they'll often deglove as a unit where both of them will fail simultaneously. When we put the patient into inversion and then we do some dorsiflexion, plantarflexion, you can see the subtalar joint underneath here. This is some fluid in the subtalar joint, and you can see the way that the calcaneal fibular ligament tightens in this normal volunteer, and the peroneal tendons almost appear to bounce on a trampoline type effect, and this tells me that the calcaneal fibular ligament is intact. In this case, you can see that the calcaneal fibular ligament looks beautiful at the calcaneal end, but at the fibula end, it's really disorganized and is degloved from the fibula. And you can see that with the dynamics, there's no movement, there's no bouncing of these peroneal tendons, and that's because the trampoline underneath them, the calcaneal fibular ligament, is not holding any tension at the fibula end because of its disruption. The next structure is very important for the stabilization of the ankle mortise, and this is the anterior-inferior tibiofibular syndesmosis, and of course there is a posterior counterpart, which we can also see with ultrasound, but probably less reliably than the anterior one. So if this fails, when the patient weight bears, the tibia and the fibula are no longer held together, and the talus will divide these two bones apart, and this will stretch the interosseous membrane, and in fact may even tear the interosseous membrane, causing a great degree of pain for the patient. So typically people with anterior-inferior tibiofibular syndesmosis failure will not be able to weight bear, and they'll come in using crutches or a wheelchair. The angle of the anterior-inferior tibiofibular syndesmosis is important to understand because the tibial end is far more proximal than the fibular end, which is more distal. So you need a very steep angulation of the transducer, and I think of it as really angling the transducer from the distal fibula and then point the other end of the probe towards the patient's contralateral knee. That's about the angle that you need to get the AITFS beautifully orientated. And in fact, the AITFS and the calcaneal fibular ligament almost make a straight line. So if you've got the transducer in the position for the CFL, which we've just done, if you slide the probe up onto the other side of the fibula, you really line up on this structure really quite beautifully. When this structure fails, it often takes a bony avulsion with it. You can see the way that bony avulsion has come off there, and you get this hematoma sitting in the spot. So when you have an AITFS rupture, it's usually a significant injury. In this case, it's not a complete rupture, but it looks very swollen and disorganised and heterogeneous and hypoechoic. And when you compare it to the other side, this beautiful, tight, linear collagen arrangement, you can really see this is a significant strain injury of the anterior inferior tibiofibular syndesmosis. The next ligament we'll look at is this one, and this is the bifurcate ligament here. And in this one in particular is the calcaneal-cuboid component of the bifurcate ligament. So if we slide the transducer across the calcaneum here and just keep it in this orientation so you're parallel to the sole of the foot, you'll see a little step in the bone as you move from the calcaneum to the cuboid. There's a little step down in the bone. Then if you slide the transducer up towards the dorsum of the foot, the step in that bone increases in steepness, and then just before you lose the cuboid, you'll see the CC ligament reaching down in this manner here. So this is the calcaneal-cuboid ligament. Over the top of it, you always see a muscle, and this is the extensor digitorum brevis muscle sitting over the top of it, and that makes its origin just proximal here, and this is the bit of bone the eyes need to go for, because this is the anterior tubercle of the calcaneum. It corresponds to this bit of bone here, and this is the piece that will be fractured as with an inversion injury. As the cuboid rotates internally or into plantar flexion, it will destroy this piece of the calcaneum, causing a fracture here. So this is such a case, and you can see the fairly large avulsion fracture coming off the calcaneum there, while the cuboid end of the CC ligament's fine, and over the top of that avulsion fracture you can see the extensor digitorum brevis muscle belly making its way across the top of it. So this is typically what the patient presents like. They really do have extensive bruising and swelling, and when I see this degree of bruising and swelling, I really am looking for a fracture, and it might be a fibular fracture, but once I have excluded that, then an anterior tubercle or anterior process of the calcaneum, where the calcaneal-cuboid ligament has its origin, is the next most common fracture that will explain a foot and ankle that looks like this. Then we have the dorsal talonavicular. This is this ligament here. So if you put your transducer in the sagittal plane, just like you're doing the anterior ankle joint, so you're lining up the tibia with the talus, slide the transducer inferiorly, the first articulation you get to is the talonavicular dorsal articulation. You'll see the ligament sitting across that joint very beautifully. With a plantar flexion injury, that's what's going to pop this ligament and cause disruption. And you can see here, in this case, how there's been an avulsion fracture from the navicular end. You can see it on the lateral radiograph, and you can see it beautifully on the ultrasound. The mechanism for this injury is a plantar flexion injury. So it may be sure an inversion injury, but inversion with plantar flexion will cause this disruption. Then we look at the medial side, and if we look at the medial side, we're considering the deltoid ligament complex. We've got the tibiotalar component, the tibiocalcaneal component, and the tibiospring component, and the tibionavicular component. So the important parts for me are tibiotalar. We look at this in dorsiflexion and eversion. That'll tighten this up. And then we're looking for a crush injury here, where we're going to have hyperemia and synovitis of this. Then we come more anterior to the tibiocalcaneal component, which is from the medial malleolus to the suscentaculum tali of the calcaneum. And this is where we're going to get degloving injuries of this ligamentous complex and the flexor retinaculum from the medial malleolus of the tibia. Then we have tibiospring and tibionavicular. So this is your POMI lesion. It stands for posteromedial impingement. And so what we have here is that during an inversion injury and an ATFL failure, the medial malleolus of the tibia is now collided with the medial aspect of the talus. And these little, you can see multiple collision fractures here. You can see the little bony ossicles sitting in the articulation now. And then you can see the hyperemia of this tibiotalar deltoid ligament complex, which is all of this complex here. It's quite a broad structure. This is tibialis posterior, and this is the flexor retinaculum coming across here to its origin. And you can see the way that the deltoid ligament and the flexor retinaculum make a conjoint structure to attach onto the medial malleolus. So this hyperemia is a POMI lesion. If I see this hyperemia immediately after an inversion injury, I just report this or put it on my worksheet as just being post-traumatic hyperemia. But after a few weeks after the injury, then if you still have this hyperemia pattern, this is a chronic synovitis, and then I consider it to be a posteromedial impingement lesion. So very common, and use your Doppler and relax. So you're going to have this patient in eversion, dorsiflexion, to get nice B-mode images, but then you need to relax it a little bit to get your color Doppler. So we have compression of this component of the deltoid ligament, but then we have our tears of this component. So more anteriorly placed on the medial malleolus, we have the flexor retinaculum and the tibiocalcaneal / tibiospring component of the deltoid ligament complex that become lifted away from the periosteum or the attachment onto the medial malleolus of the tibia. So we have our normal anatomy of tibialis posterior with the deltoid ligament underneath and the flexor retinaculum on top coming together and having a nice origin here on the medial malleolus. So I term the word liganaculum for this because it's a conjoint structure between a ligament and a retinaculum, and they have a nice attachment here. When it fails, it's quite dramatic, and you can see the way now that tibialis posterior is destabilized because the flexor retinaculum coming over the top has been degloved and elevated from the medial malleolus, and you get this hyperemia pattern in amongst the heterogeneous, disorganized looking collagen. More examples of the same, and you can see beautifully here the periosteal stripping. So you can see the way that's lifted away from the medial malleolus, and you can see the way that's elevated some of the calcified fibrocartilage components of that enthesis in a beautiful stripping manner. The next structure we'll have a look at is the plantar fascia. And so reference image 1 of the plantar fascia is obtained by getting underneath the foot, putting the transducer in this sagittal orientation. You can see the plantar fascia having its origin from the calcaneum, and in particular, you want to be on the medial aspect because this is where most plantar fasciitis will happen. Then we can turn transverse for reference image 2, and you can see the way that the plantar fascia is attaching onto the calcaneum here at its origin. So we look at the enthesis, we look at the plantar fascia collagen itself, we look at the fat pad adjacent to it. So remember the fat pad underneath, so on the plantar side of the plantar fascia has the macro chamber, the very spongy type of fat pad, and then the micro chamber, which is the stiffer part. So we can sometimes get fat pad edema or even a split tear in that fat pad. Next to the fascia, we sometimes get some thickening or some edema in the tissues adjacent to the fascia, like a perifascial edema. And then if we look deep to the plantar fascia, the next muscle we see is the flexor digitorum brevis muscle sitting underneath. We can also have a look at the abductor digiti minimi muscle, because if you turn transverse on the plantar fascia and you scan more distally down the foot, you'll see the plantar fascia sitting on the flexor digitorum brevis muscle belly, and then deep to that is pronator quadratus. So, quadratus plantae. And then if you move the transducer to the lateral side, so towards the little toe, the next muscle you get to there is the abductor digiti minimi muscle that you'll see passing over the top of the cuboid bone, with the peroneus longus sandwiched between the cuboid and the abductor digiti minimi. Now, the reason this muscle is important is because this muscle becomes de-innervated when the first branch of the lateral plantar nerve, so the so-called Baxter's nerve, is in poor functional health. So the diagnostics are to look at the enthesis, of course, for enthesophytes and for enthesopathic changes. We look at the plantar fascia for its fusiform swelling and its altered echogenicity. We look at the fat pad to see if there is any fat pad trauma or any inflammatory change in the fat pad, and abductor digiti minimi looking for fatty atrophy change for a Baxter's nerve entrapment. So we can have, in the plantar fascia, we can have three basic patterns. You can have plantar fasciitis that occurs at the medial side at the calcaneal origin, or at the base of the fifth metatarsal where the lateral band inserts. We can have a rupture of the plantar fascia, which happens just distal to the plantar fascia origin. This is also where we can get nodular plantar fasciitis in this area. And then you get plantar fibromatosis, or Lederhaus disease, in the more distal part of the plantar fascia, which is the same as a Dupuytren's contracture in the hand on the palmar aponeurosis. So your classic pattern is to see plantar fasciitis here, focal nodular fasciitis here, and you can see this is a fairly global type pattern where it's a fusiform swelling that involves the entire thickness of the plantar fascia. Or you have this plantar fibromatosis pattern where you have preservation of the deep fibres, and it's like a nodule coming off the plantar side of it with the deep fibres being quite well preserved. So this is classic plantar fasciitis. You can see the thickening of the plantar fascia origin here. This is focal nodular fasciitis, where we can see a nodular thickening just distal to the origin. Here's another nice example of focal nodular fasciitis. And then this is plantar fibromatosis, or Lederhaus disease, and you can see very nicely the way the deep fibres are perfectly preserved, and it sits like a nodule off the plantar side of that deep fibre preservation. So this is the classic pattern and how you differentiate it from the focal nodular fasciitis. You can see again the deep fibres here are quite preserved, and it's like a little nodule. In fact, it's multifocal here on the plantar fibromatosis pattern. Next, we'll move into the forefoot and have a look at some causes for metatarsalgia. And the first example I have here is some adventitial bursitis of the fat pad. So you can see the fat pad is made of a macro chamber here, which is the spongy part of the fat pad, and then the micro chamber here, which is the more densely packed component. We don't have a bursa sitting underneath our metatarsal heads, but if you have been repetitively stressing this fat pad, then you'll get this change, breakdown in it, and liquefaction really. And this is an adventitial bursa, and with very light transducer pressure you can appreciate this, and then you can test it for vascularity, and you can see the hyperemia here. It's important to use very light transducer pressure, because if you use too much transducer pressure, you can see that you get compression of this fat pad, and you can't appreciate the adventitial bursitis. So you can see the way the fat pad has become quite edematous here, and is focally tender, and it really is just a localized edema, almost giving a cobblestone appearance, and it's immediately adjacent, typically to the first or second metatarsal head where the weight bearing occurs. If we look at the forefoot, we have a lot of fairly complex anatomy. This is the transverse intermetatarsal ligament that connects the metatarsal heads together. And on the plantar side of that, we have the digital nerve. So to assess the digital nerve directly, I like to approach from that plantar aspect rather than from the dorsal aspect. On the dorsal side of the transverse intermetatarsal ligament is the intermetatarsal bursa. So this can be well seen from the plantar or from the dorsal side. And then immediately underneath the metatarsal head, we have the plantar plate, which then has the flexor tendons anchored onto the top of it. So we have quite a lot of interesting anatomy to assess here. The plantar plate is made of fibrocartilage, and you can see it has a typical fibrocartilage appearance, very much like the spring ligament, for example. And it in fact just is in fact the plantar aspect of the joint capsule of the metatarsophalangeal joint. Where it fails is here. It fails at its attachment onto the proximal phalanx, and it has very loose connective attachment here to the neck of the metatarsal. So this is a nice example where we have the proximal phalanx here. This is the plantar plate, and the metatarsal has in fact been removed to expose this nice plantar plate here. So this is what normal plantar plate looks like. It often has this triangular echogenic structure sitting in the centre of it, just adjacent to the base of the phalanx, and this is a normal variant. We see this all the time. And then this is an accessory sesamoid. So not your typical sesamoid like we have in our hallux, but this is another accessory sesamoid. So these are all normal variations. Nothing to worry about here. This is something to worry about. Now, when you have a toe that looks like this, you can see there is elevation of the second toe, and there's also varus drift, where it has drifted across and it's almost trying to sit on top of the great toe, and then it has also formed a callus here where it's been rubbing on the footwear. When I see this pattern, I'm fairly certain that that second plantar plate will be torn. So when we come underneath the foot here, we can actually then see the digital nerve, and from scanning from underneath the foot, this is in fact the digital nerve, and this is in fact my finger pushing from the plantar side. So I'm compressing the little bursa here. This is the transverse intermetatarsal ligament, and this is the digital nerve. I'm lifting up, and you can see it beautifully. And if we're going to have any Morton's neuroma, it's going to be in this area here. In this case, there's no Morton's neuroma. We just have a very spongy bursa and a very nice normal looking nerve. And it's this deep line of the nerve here, this line here of the nerve. So this is on the dorsal side of the nerve. This is nice and clean and uninterrupted. If we have a Morton's neuroma, then you'll lose the cleanliness of this line. That's the diagnostic criteria I use. And this is the technique. So we're putting compression from the plantar and the dorsal side, and that's how we're lifting that nerve up and giving that really good visualization. So scanning from the plantar side, finger from the dorsal side, and putting that firm pressure on. So we're doing that here, and in this case we can see we have certainly some compressible bursa here, but we also have a non-compressible neuroma sitting over the top. So there's the non-compressible neuroma. This is the transverse intermetatarsal ligament here. This is the normal digital nerve, and this is the perineural fibrosis of the Morton's neuroma. Another nice example, you can see I'm getting my finger into the correct location and then compressing, and you can see that there is a real loss of the cleanliness of this deep line of the nerve and a fusiform swelling here. And this is the perineural fibrosis typical of a Morton's neuroma. It's very common to get a Morton's neuroma and a bit of bursal fluid together, so this is the so-called bursa neuroma complex. It's also very common just to see a bursal effusion, so just bursitis with no neuroma. Look, I hope you've enjoyed this discussion about the ankle and foot, and I think there's many great ways that ultrasound can be applied to assessing injuries and sources of pain in this part of the body. Happy scanning, and bye for now. Now we're going to have a look at the ankle ligament apparatus, and when we assess ankle ligaments, it's most commonly following an inversion injury. Now, there's a lot of ankle ligaments that we can have a look at, and I'll take you through each and every one of them that I think is most important for a standard protocol examination for an inversion injury. I'm not going to go back over the ground of having a look at the ankle joint and the subtalar joint for effusions, but because I've covered that in a separate presentation. However, this would be integral to looking at my ankle ligament assessment protocol. So the first thing I'm going to have a look at is the anterior talofibular ligament. So this is the lateral malleolus, and if you put your thumb underneath the lateral malleolus like so just slide it up until it sits underneath the lateral malleolus, and then put your transducer just resting on the top of your thumb and put it parallel to the sole of the foot with the ankle in this bit of natural inversion, you'll be sitting right on top of the ATFL, the anterior talofibular ligament. This ligament, of course, goes from the fibula to the talus, and it's most commonly torn ligament with an ankle inversion injury. The second ligament that I like to have a look at is the calcaneofibular ligament. So the calcaneofibular ligament, I start with my transducer in this location, and I come down, and the first thing I look at is I see my two peroneal tendons, and then I see the superior peroneal retinaculum. I want to make sure the superior peroneal retinaculum is okay, because this can be stripped in the case of an inversion injury. I now come around a little further, and when I'm pointing the transducer between the fibula and the middle of the calcaneum here, that's when I'm going to see my calcaneofibular ligament. If I end up seeing the peroneal tubercle, I've come too far, and if I see the sinus tarsi, I've come way too far. So you need to come right back until you're on the CFL, and to get the calcaneofibular ligament with its perfect image, you need to do some inversion and dorsiflexion, so bring the toes in and up, and that tightens the calcaneofibular ligament, and that'll allow you to see this fibular attachment with much more clarity. In fact, if you then go into this sort of plantar flexion and dorsiflexion type movement, you'll see the calcaneofibular ligament bouncing lifting up the peroneal tendons like bouncing them on a trampoline, and this proves that it's intact and it hasn't been stripped. When the CFL does fail, it doesn't fail from the calcaneal end, it fails from the fibular end, and often it fails concurrently with the anterior talofibular ligament. So it's almost like, I think of this really as a continuous sheet of collagen from the talus to the fibula and then to the calcaneum, and it can deglove as one complete sheet, and this is quite a common pattern of injury that we can see here. The next structure that I'll look at is the anterior inferior tibiofibular syndesmosis. So the AITFS, if we start with the anterior talofibular ligament, to go from this transducer location to the anterior inferior tibiofibular syndesmosis, or if you like, the tibiofibular ligament. The reason it has a long name is because there are superior components and there are posterior components. So anterior inferior tibiofibular, and it's called a syndesmosis because it's quite broad and strong. So what I need to do is I need to keep from my ATFL position, keep my fibular end of the transducer stationary and move my distal end of the transducer up until it is pointing more superiorly here, really towards the patient's opposite knee. So I rotate around, and when I'm halfway through the rotation, I can still see the fibula, and another bone will appear on the screen, and this bone will have hyaline cartilage, black hyaline cartilage in a triangular fashion on top of it, and this is the talus. So this is not the bone I'm after. I need to continue the rotation even further, all the way around to here, and then I'll see the fibula and the tibia. And then between those two structures, I'll see the anterior, inferior, tibiofibular syndesmosis. In fact, when you've got the correct location, the transducer angle will make a direct straight line with the calcaneal fibular ligament. So once you've got the AITFS, if you then bring the transducer down to the other side of the fibula and use this inversion and dorsiflexion, you'll be lined up on the calcaneal fibular ligament. So those two structures make a very straight line. The next thing that I like to do is just follow the peroneus brevis until I see the base of the fifth metatarsal, because I just want to check that for a Jones fracture, because that's quite a common problem when we have an inversion injury and ligamentous injuries. The next thing we'll do is we'll have a look at the calcaneal cuboid ligament. So the calcaneal cuboid ligament, if you just follow the calcaneum and then you follow it to here, you'll see another bone will appear, and this bone will have a small step down to it, and this is the cuboid. And once I find that small step down, if I then move the transducer to the anterior, so more to the anterior side of the ankle this way, as I move the transducer, this step will widen. And just before you lose these two bones on the same image, that wide step will have a band of collagen running obliquely between it. And this is the CC ligament, or the calcaneal cuboid ligament. This is part of the bifurcate ligament apparatus. And so the bifurcate ligament is the calcaneal cuboid ligament, and also another sling that goes from the calcaneum to the navicular, which I don't really see well with ultrasound. But what happens when we have a hindfoot stabilisation and midfoot internal rotation injury is that the anterior tubercle of the calcaneum will become fractured through an avulsion fracture. So the CC ligament will fail at its proximal end, and it will take with it a piece of bone. This is the most common thing we see. The patient will have extensive bruising and swelling on the lateral side of the ankle. So there's a lot of bruising and swelling around here. I think of an ATFL, CFL, maybe a distal fibula type fracture. If it's more in this part of the foot, then I really consider the fact that the anterior tubercle of the calcaneum might be what's failed here. The next thing I have a look at is the dorsal talonavicular ligament. And the reason I do this after the calcaneal cuboid ligament is because they both lay in the same plane in the foot. There's a natural plane of weakness that runs through the foot here. So I start with looking at the ankle joint, and I come distally. And when I get to this point here, I can now see the talus and then the navicular. And with the transducer straight in the midline, you'll see the dorsal talonavicular ligament. And so the dorsal talonavicular ligament will fail concurrently with the calcaneal cuboid ligament through this natural plane of weakness through the foot. So this is the Charcot plane that runs through here, and this is where we'll have these two injuries. There's really three planes of weakness through the foot. The Charcot line through here, the Lisfranc line, which runs through the metatarsal bases, but this is protected a little bit by the first metatarsal being short compared to the second metatarsal, so the medial cuneiform could form like a block to at least put a step in that plane through there, and that saves us from having our metatarsals simply shearing off our tarsal bones commonly. And then of course at the head of the metatarsals, this is another weak plane through here. So we have the Charcot plane, we have the Lisfranc plane, and then we have a plane through the heads of the metatarsal. These are the three planes of weakness that we have through the foot. So it's important to understand that the CC ligament and the dorsal talonavicular ligament can concurrently be injured together. If we then turn our attention to the medial side, if we just bend this knee and we'll bring this foot down, you think, why would I look at the medial side for an inversion injury since the foot's done this? So with the inversion injury, sure, we rupture our ATFL, our calcaneal fibular ligament, we may do a Jones fracture, we may damage our anterior tubercle of our calcaneum, we may damage our dorsal talonavicular if there is a plantar flexion component to it. But how can we damage things on the medial side? And on the medial side, what happens is a compression injury. You can see as this happens, we get the Contracou compression injury. So what we need to do is we need to walk down this medial side and have a look at the joint capsule ligamentous apparatus of the deltoid ligament. So as I come down, I start at this level here, so just looking at tibialis posterior sitting on the surface of the medial malleolus. I then follow tibialis posterior down until I see tibialis posterior starting to separate from the bone of the medial malleolus. And as it separates, immediately underneath it will be the tibiotalar component of the deltoid ligament complex. And this is the component that gets a compression injury with an inversion event. And once it has been compressed, then because the deep component of it has a lot of synovium built into it, it gets a synovitis. And this is what we call a POMI lesion, a posteromedial impingement lesion. So if it's a fresh inversion injury and there's hyperemia here, this is just post-injury hyperemia. But if you're seeing this patient a few weeks after their injury and they've still got posteromedial tightness and discomfort, this is a POMI lesion, P-O-M-I, posteromedial impingement. If you then continue to see the posteromedial impingement component, the tibiotalar part of the deltoid, the posture of the foot's important. We need to have the foot in eversion and dorsiflexion, so out and up, and this is the perfect position, and that'll tighten the tibiotalar ligament and make it look really quite elegant for you. However, this is not ideal for having a look for the hyperemia, for the POMI lesion, so then you need to relax it. You accept the B-mode image is degraded, but then you'll see the flow when you use your Doppler. If you then bring the transducer further around, and in fact you're going to be at 6 o'clock from that medial malleolus when you're straight down there, you're going to see the tibiocalcaneal component. So this is the component of the deltoid ligament that goes from the medial malleolus to the suscentaculum tali of the calcaneum. And then if we come a little bit further around anterior, so we'll be between the suscentaculum tali and the navicular. Of course, when you're between those two structures, you're going to see the structure that connects them in short axis, and the structure that connects the suscentaculum tali and the navicular is the calcaneo-navicular ligament, which you may well know as the supramedial portion of the spring ligament. So you're going to see the tibio-spring component of the deltoid ligament, and you're going to see it attaching onto the spring ligament itself. Now the spring ligament doesn't look like collagen because it's really made of fibrocartilage, so it has that mothy fibrocartilaginous appearance to it. Why do we need to look at this? So we've got two patterns of injury that I like to look for here. The first are the compression injuries in tibiotalar, and then when I get to the more anterior part, and I'm looking at that tibiocalcaneal, tibiospring part, I'm looking for a degloving type injury where the flexor retinaculum and the deltoid ligament coming up from underneath form a conjoint attachment onto the medial malleolus, and this is degloved from the medial malleolus, causing pain for the patient in this area. And this is not an uncommon thing to see with an inversion injury. The spring ligament itself, you can see, and it's not really part of my inversion protocol, but I'll go through it quickly just to show you how we find it. If you follow the tibialis posterior around the medial malleolus, and then you keep following it around, you identify the suscentaculum tali, and then once you get past suscentaculum tali, you will see that deep to the tibialis posterior tendon is in fact the spring ligament. And so you can see it, the layers of anatomy, you'll have tibialis posterior, and then the spring ligament, and then you'll see the talus with the hyaline cartilage. And that's what you're going to be seeing. You're going to be in the short or slightly oblique axis of the spring ligament. If then you turn the transducer around so that it's parallel to the sole of the foot, you angle up slightly with your transducer and you put the foot into eversion, then you're going to line up posteriorly the suscentaculum tali, anteriorly the navicular bone, and like a bow tie type shape, you're going to see the spring ligament arching between these two structures. Deep to it, you're going to see the hyaline cartilage of the talus and the talus bone, and superficial to it, you're going to see an oblique axis of tibialis posterior. So the mysterious supramedial spring ligament is really not that hard if you follow those simple instructions. In this demonstration, we'll walk through the ligamentous anatomy of the ankle, and I'm starting with the most commonly injured ligament in the lateral ankle with an inversion injury. This is the anterior talofibular ligament. So I've placed my finger just underneath the lateral malleolus, and now the transducer is just resting on my finger, parallel to the sole of the foot, and I've got the ankle with a bit of passive inversion. This is the fibula, and this is the talus, and you can see the lovely collagen branching between these two bones. This is the anterior talofibular ligament. It's of course part of the joint capsule, so underneath it you always have some fluid, and that's just the synovial fluid of the ankle joint. You may also notice this little triangle of echogenic material here. This is just a little piece of fat sitting inside the ankle joint, so we see this very commonly here. So this is a normal anterior talofibular ligament. The next ligament that I look at, and it's really just for ease and simplicity, is the anterior inferior Tibiofibulous Syndesmosis. So what I'm going to do is keep this end of the transducer stationary, the fibular end, proximal end, and the distal end, which is the talar end, I'm going to rotate that end of the transducer until it's pointing about towards the patient's opposite knee. So as I make this rotation, you're going to see the bones change, and immediately the bone on this side, you can see it's covered in hyaline cartilage. And that tells you this is not the bone that we're looking for. It tells you this is the talus,
And what we're trying to do is line up the fibula with the tibia. So we need to continue the rotation until this disappears. So we continue around, and it's disappearing now. And just as it disappears there, you see another collagen band sitting between these two bones. And this is the anterior inferior Tibiofibular Syndesmosis. So this bright band of collagen running between these two bones, this is the fibular end and this is the tibia end, and you can see there's a nice structurally supporting band running between them of collagen. So this is the anterior inferior Tibiofibular Syndesmosis. It's an interesting fact that this lines up perfectly with the Calcaneal ligament. So if I'm going to take the transducer, we'll look at this ligament next, which means I'm going to come back to my lateral malleolus and find my peroneal tendons. There's the superior peroneal retinaculum, peroneus brevis, peroneus longus. This is the fibula, and now we're going to come around, and there you can see just underneath here, underneath the peroneal tendons, this is the Calcaneal ligament. Now you can see this is not a particularly good picture of it because it's very hammocked. It's not on tension. So what I'm going to do is I'm going to, instead of just having inversion, I'm going to introduce some dorsiflexion, and you can see what a dramatic difference that makes to this ligament, how it really tightens it up there. And now we've got the Calcaneal ligament really as a very, very straight structure. This is the fibula here. This is a little bit of fluid that we've pulled out of the posterior subtalar joint because of this inversion and dorsiflexion. And you can see peroneus brevis and peroneus longus sitting on top of the Calcaneal ligament. Now, one of the dynamic tests we can do for the structural integrity of Calcaneal ligament is to apply and then release this inversion dorsiflexion. And as we do this, you'll observe that the peroneal tendons will bounce up and down almost like on a trampoline. And this tells us that we can produce tension inside the Calcaneal ligament, and it's in fact intact. When this ligament fails, it fails from this end typically, which is the fibular end, and you can see the way that the fibres of this Calcaneal ligament wrap right around the fibula, and then if you follow them, they really become continuous with the anterior talofibular ligament and forms like a continuum of collagen right over the top to sort of seal shut that joint capsule. And in fact, when it fails, they can fail and deglove together, so you can have a simultaneous anterior talofibular ligament and Calcaneal ligament failure from that fibular end. It's quite unusual for it to fail from this end, which is the Calcaneal end. The next ligament that I like to look at is the CC ligament, or Calcaneal Cuboid ligament. So I'm just on the calcaneum now. I'm just sliding the transducer until I see a little step in the bone. Now that step there indicates that I've arrived at the articulation between the calcaneum and the cuboid. So I line this articulation up, and then I'll just move the transducer a little bit to the dorsal side, and we have this really beautiful band of collagen that's sweeping between these two bones here. And this is part of the bifurcate ligament. So this is the Calcaneal cuboid component of the bifurcate ligament, with of course the other sling going between the calcaneum and the navicular. But this is the most important place here to put your eyes, because the distal end of the CC ligament is rare to fail. However, the proximal end will cause an avulsion fracture here of this anterior tubercle of the calcaneum. And this is where we're going to see our avulsion fractures very commonly. These people will present having had some hindfoot stabilisation and midfoot internal rotation, and the fracture here will of course bleed, and they'll have a very bruised and swollen lateral side to their ankle and midfoot. The next ligament that I'll look at, if I come right back to where I started my examination of not so much the ligaments but just of the general ankle structure, we remember this articulation which is between the talus and the navicular. So this is the dorsal talonavicular, and you can see this lovely band of collagen through here. This is the dorsal talonavicular ligament, it's quite thick from here to here, and this can be injured with plantar flexion injuries. The next ligament that I look at is on the medial side. So now I'm coming back around to my medial malleolus, and I can see beautifully the tibialis posterior sitting on top of the medial malleolus of the tibia, and there's our flexor retinaculum over the top. Now as I come down, follow tibialis posterior down, you'll see that it has now come away from the bone. So there's the tibia, and there's our tibialis posterior, and there's this fairly untidy looking triangle of collagen in here, and this is the most posterior part of the deltoid ligament complex. This is the tibiotalar component of the deltoid ligament. So this is the part of the deltoid ligament that suffers a compression injury as part of an inversion injury. So I need to put this on tension to have a look at the architecture of it. To put it on tension, I do eversion and dorsiflexion. So as I do this, you can see it's straightening out the collagen lines within it, and now it's quite an attractive ligament. So you can see the very superficial fibres here, densely packed collagen. This is the external component, and this is important for structural integrity. The deeper part has this sort of striated appearance, and this is because there's a lot of synovium and some fat interweaved with the collagen here. This is the tibiotalar part of the deltoid. So we need to come undo that tension a little bit, let it just crinkle up a little bit, and then use our Doppler to have a look at this component, looking for flow in the deeper part of it, and this is the so-called POMI lesion, P-O-M-I, posteromedial impingement lesion. I'm now going to continue to rotate my transducer around. I'm going to keep this end stationary, really, and this is the tibial end, but the more distal end I'm going to move more anteriorly until I arrive at about a 6 o'clock orientation to the medial malleolus. And as I do that, you can see that this bone, which is the talus, is replaced by another bone further posteriorly, and this is the sustentaculum tali of the calcaneum. So between this and the medial malleolus, if I put a bit of eversion stress on, you can see there's another band of collagen connecting these two, and you can see it shiny in the middle there. I'll just put a little cursor on it so you can see it, that it runs from here and it's going to right be in this location, and you can see that it's nice and shiny and bright, and that's the tibiocalcaneal component of the deltoid ligament. If I then move the transducer, the distal end of the transducer this end, more anteriorly, I will lose this bone, so I'm now coming in front of the sustentaculum tali, and when I lose that, it's replaced by this structure. So this is the sort of grey structure that's sitting, this is the talus, this grey structure is what we're looking at, and this is tibialis posterior on top. And then we have the medial malleolus, and this is the tibiospring component of the deltoid. So this is talus, this is the supromedial portion of the spring ligament, or the calcaneal navicular ligament, and then this is tibialis posterior. Now this part of the deltoid ligament is susceptible for tearing during an inversion injury, and where it happens is at this end. So if you look at this part of it over here, you can see the tibiospring component through here, and then on the top you can see the flexor retinaculum. So there's tibialis posterior, and this is the flexor retinaculum. Now these two structures now amalgamate at this junction here, forming a V-shaped structure, and then you can see they have this little elegant attachment making their origin from the medial malleolus of the tibia. Now with an inversion injury, this V shape of collagen is stripped from the bone in a degloving manner, and this is what we'll see. We'll see the periosteal stripping here, and you'll see the disintegration of this piece of collagen as it's stripped from the medial malleolus. And this is all part of the spectrum of an inversion injury that you can expect to see. We'll have a look at the spring ligament itself. So if we come down tibialis posterior, I did touch on the spring ligament as we came down. You can see that it's interspaced here between the tibialis posterior and the talus. So we have the talus with its hyaline cartilage, the supromedial portion of the spring ligament, and tibialis posterior. So you can follow, that's very simple to find, just following tibialis posterior down in the short axis until you see that anatomy. But once you've found the supromedial portion of the spring ligament, if you then rotate the transducer around so that you're parallel to the sole of the foot, and then you put some eversion stress, you can now start to see the spring ligament in its long axis. So posteriorly, you can see this is the sustentaculum tali, and this is its posterior attachment. This is all spring ligament, this very thick structure. This is the talus, and this is tibialis posterior. And what that means is if I keep coming more anteriorly, you find another bone which is navicular. So we've got navicular here, this is all spring ligament, sort of a bow tie shape once again. This is sustentaculum tali, and this is the talus. The reason it looks grey and sort of heterogeneous is because this spring ligament has undergone transformation to fibrocartilage. So it's a fibrocartilaginous structure, and that's why it has that typical sort of mothy type appearance. I hope you've enjoyed this assessment of the ankle and the protocol that I've put together for you. I think you'll agree that it is a complex area of ultrasound, but in particular, since podiatrists have gained referral rights in Australia for referring patients for foot and ankle ultrasound, this has really led to some great referrals coming to us, which has really stretched
our capacity and enhanced our skills in assessing the ankle and the foot in great detail. And I've enjoyed this journey of learning to be able to see all this intricate bits and pieces around the ankle. I hope you've enjoyed it as much as I had. Happy scanning, and bye for now.
I hope you enjoyed this excerpt from the Fundamentals of Ankle Ultrasound. To view the complete version of this webinar, as well as all the other material contained within the website, simply click on the Shop tab at the top of the screen and then select the Subscribe option. I hope you enjoy the rest of the material. Happy scanning and bye for now.